good afternoon to you all. I'm very pleased to be here to give a talk on a very important topic. Dr. Arun, who is a pediatrician who spoke on childhood obesity, has done a beautiful job of explaining all about childhood obesity. So I'm going to enlighten you all about adult obesity and what we could do about it. So in that context, I'm going to be discussing about the launch of a new peptide in a pill. So these days, our perception for body image has changed. So when Dr. Arun put up pictures of 5 animals and a human being, I heard someone telling they're all normal size. So we have started accepting that having a little bit of tummy when a man is 45 years old, or having a few, double chin or flappy tummy once the mother has given birth to children is normal. So we think that when you're 40, it is normal to put on weight. Or it's easy for us to blame, saying that it's all about hormones. I eat less, I do work out, but I'm still fat. It's because my parents are obese. So it's very easy to shift the blame onto something else rather than taking ownership of why you are the way you are. So what is happening in India? 1 in 10 of us have got diabetes. So in this audience, you can imagine 1 in 10 of you has got diabetes of some sort. Of that, 67% of people in India with diabetes are obese. So 67%, that's a huge number. And this is not something new to India. All over the world, obesity rates are increasing, and no one single country has been able to slow this process of increasing obesity over the past few decades. So is this something new? There are references from prehistoric times. These are just 11 centimeter figurines discovered about 30,000 years ago. They have been carved, but they've been discovered about in 1906. And these are called the Ice Age figurines, Venus of Wildenhof, and they were found in a village in Austria. So these figurines are of females. And there are a lot of theories about what these figurines actually depict. Some say fertility, some feel they are the mother of goddess, beauty. But these could also be perceived as probably obese people existed during that period as well. And when we look into the Hindu mythology, one of the kings, Kumbhakarna, the Rakshasa, the king, the brother of Ravana. When we look from the endocrine perspective, he used to eat a lot and sleep a lot, and we wonder, and it has been mentioned in the endocrine journals, if he had some kind of a hypothalamic dysfunction which controls both appetite and sleep. There are also theories that he ate a lot and he developed hyperosmolar or hypoglycemic state, and he was in a deep coma, which was exaggerated. Or if he had obstructive sleep apnea. So these are all theories of what could be wrong with Kumbhakarna. So it has been referenced in several textbooks and from our mythology that obesity is not something new and it is not normal. This is one of the earliest case reports of a boy from Mumbai city. They found this 8-year-old boy who was wandering the streets. He was an orphan. So that's what the case report states. He was an orphan and he was fed by people who found him on the streets, and over a period of time he has put on a lot of weight. And this is just a short report of how he looked. He was otherwise a very active, cheerful child. So he did not have any kind of syndrome, look from the way it's been described. But he did have buried penis, so he did not have male external genitalia that was very obvious. So this is not something that is just described in the literature in the 1859. This was published in Lancet. I do get patients referred from urology and from the pediatricians to exclude any kind of hormonal abnormalities in children who the parents feel that they're not going through puberty because their glands, penis is not very well developed. And it's up to me to say, no, it's just there. You can't see it because it's buried. So we see a lot of childhood obesity even as adult endocrinologists. And we have moved on from perceiving that obesity is a disease or a condition that used to be seen only in the wealthy population. So in the olden days, if you're fat, if you're obese, that means you had a lot of wealth. You had a lot of food to eat, you had access to eat. So mostly it's the kings who are depicted to be very well built and the slaves are very thin. So we moved from thinking that obesity is something as a symbol of wealth and prosperity to an epidemic of the 21st century. So the complications due to increased body weight are many. The cardiovascular complications, as we all know, stroke, coronary artery disease, and peripheral vascular disease. But we should also remember there are non-cardiovascular complications that we fail to understand and recognize in our general practice. Depression is very, very common in the obese, hypertriglyceridemia, osteoarthritis, obstructive sleep apnea, gastroesophageal reflux, urinary stress incontinence, and non-alcoholic fatty liver. All these are very, very under-recognized in our clinical practice. All we talk about is just obesity and diabetes, or obesity and dyslipidemia, but a significant proportion of our patients can have obstructive sleep apnea and depression, non-alcoholic fatty liver. There is a sinister synergism because they both kind of interlinked. The biggest endocrine organ in our body is actually fat. It's not the pituitary. Pituitary is the master gland, but the biggest endocrine gland is the fat. So a lot of things that's in the environment that triggers obesity: food, physical activity, safety, and alcohol. All this drives the adiposity. This again triggers sleep disorders, inability to be active, and stigma and impairment of mental health. And there's also medication-induced weight gain, neuropathy and decreased activity, hypoglycemia, and stimulation of food intake, all this in a diabetic patient. But the burden of obesity, we need to understand that it's not okay to be obese, especially if you're a diabetic. As I said, 1 in 10 of us have diabetes, now of which 67% of our patients are obese, and the rest 20% are overweight. So it's nearly 87% of our patients might have all those complications that I have mentioned that we have not screened the patient for. So 1 in 10 adults are obese, 4 in 10, which is a significant proportion of our population is obese. And there's a 7 times increased risk of all-cause mortality in our obese patients. So it is not okay to have central obesity when you are in your 40s. You should look after your health, your physical well-being throughout your life. So what happens? How do you tell this to your patient? I wish that our diabetic patients are symptomatic with severe polyuria, polydipsia, or neuropathy pain when their HbA1c is around 7 or 7.5. Unfortunately, our patients are asymptomatic even if their HbA1c is more than 10. So they present to us very late, only when they start developing neuropathy or when they get swollen legs and they're worried it could be a kidney problem, or very, very late when they have got triple vessel disease. At that time, we have already missed the whole period where we could have done a lot to our patient. So when I see a patient with a HbA1c of 8%, I tell them, if I reduce 1% of your HbA1c, then I reduce the risk of your lower limb amputation by 43%. In other words, a patient is more scared of getting a heart attack or losing a kidney rather than just the blood sugar levels, because blood sugar of 300, they don't feel anything. So most of the patients are quite argumentative. They listen to the cardiologist and nephrologist, but not to a general physician or a diabetologist when we say we need to improve the control. And that is why 75% of our Indian diabetics have a HbA1c of more than 7%, because simply there is clinical inertia, because they do not want to be treated unless it is causing them harm. So in a way, as physicians, when we talk to our patients, we can tell them, when you reduce 1%, you reduce the cardiovascular disease risk by 25%. So 1% HbA1c is equal to reducing the risk of cardiovascular disease by 25%. And I usually ask the patients to repeat this to me so that they do understand the seriousness. So I tell them, so now you tell me how many percentage we need to reduce. So all my patients, I kind of drill it in their mind that they'll have to get to this magic number of less than 7%. So when a patient is obese, the risk of stroke goes up by 33%, coronary artery disease by 49%, and all-cause mortality goes up by 73%. So it is not enough that we address just the glycemic control. We should address obesity, which is the underlying cause for diabetes in many of our patients. And what are the agents we have? These are the standard agents that we have. So metformin and the glitazone, the pioglitazone, improves insulin sensitivity, but pioglitazone, sulfonylurea, and insulin can put on weight. DPP-4 and metformin are weight neutral. Alpha glucosidase inhibitor doesn't do a lot. SGLT2 inhibitor and the GLP-1s are the only two groups of drugs that helps a patient lose weight. But those are the drugs that we don't use as often as we use metformin and sulfonylurea. Throughout India, we use metformin and sulfonylurea as the most common drugs. Those are the first and the second line drugs that we use, while we should be focusing more on SGLT2 inhibitors and DPP-4, GLP-1 inhibitors. So when we approach a patient with obesity and help them lose weight, we should start from lifestyle, diet, and behavioral changes. Behavioral change is how they perceive food, how they look at themselves. If they think they're not obese, then they're not going to lose weight. It's me who's going to keep telling them that you are overweight. You'll have to make them understand, yes, they are overweight, and the food they eat is wrong. So that is behavioral change. Just telling them to eat 3 idlis or 2 dosa is not good enough. It's a whole thought process that they'll have to adapt and change depending upon their age, their BMI, or the category of overweight they are in, and the other comorbidities they have. So it's a whole behavioral therapy. We as doctors will have to understand where they come from, their background, and motivate them to lose weight. Without that behavioral change, nothing else, the pharmacotherapy is not going to work. No matter what we do, the pharmacotherapy is not going to work. So what do we have in pharmacotherapy? We have Orlistat, which is not a great drug. You lose more money than the weight. So I seldom prescribe this drug to my patients. But we have the GLP-1, the liraglutide. We have semaglutide. And we have the other 2 drugs which is not licensed to use for obesity in India, but they're being used in states. We do have bariatric surgery and sleeve gastrectomy, but they are very expensive. And it's a one-off thing to do for patients who really need it. So what is GLP-1? So we have all come across GLP-1, but this is one of the molecules that is not commonly used. So GLP-1 is an incretin. So when you take in food and the small intestine cells, the L cells, release this GLP-1 and GIP. So GLP is glucagon-like peptide. The GIP is glucose-dependent insulinotropic. So they're both hormones, basically. They go up and they help the pancreas secrete insulin. So the insulin level goes up, the glucagon level comes down. So that is how the GLP-1s act. So this is physiology. So physiologically, the GLP-1, the GIP-1 goes up, but they get degraded by the DPP-4. So that is why they found out this DPP-4 inhibitor, which inhibits the enzyme DPP-4 and helps maintain the physiological level of GLP-1. But when we give a GLP-1 exogenously, it's a supraphysiological dose, so it acts a lot more. So it acts in the GLP-1 receptors in the brain. It helps to reduce the appetite. It works in the stomach. It delays gastric emptying. In that way, there's increase in satiety, so the patient does not eat a lot. As mentioned before, it helps increase the insulin and decrease the glucagon, but it has got other effects on the cardiovascular system as well. It increases the endothelial function, decreases arterial stiffness, and decreases inflammation. Hence, it has got a lot of cardiovascular benefit. Especially on the heart, it increases the myocardial contractility and ischemic preconditioning. So GLP-1 as a molecule itself has got a lot of pleiotropic effect compared to the other molecules that we have. So what has happened? Is GLP-1 something new that we have just heard of? No, it's not. Right in dating back to 1906, we have been aware that there is something called incretins and GLP-1 and how they function. But it's taken more than a century to get it down to what we have now. So we found out that GIP has got insulinotropic function. We have the incretin effect. We have the DPP-4, which was found in the year 2000. And now the GLP-1, up until a few months ago, was available as an injectable formulation. And we know about injectable formulation is not one of the favorites that our patients are fond of. They always want pills. They're happy to take even 10 pills, but they're scared of one injection. So again, GLP-1 is not as commonly used as any other oral hypoglycemic agents, because up until now, it has been only in the injectable form. So what has happened now? It's available in the form of a pill. So you must be wondering, has this never been tried before? This has been tried before for insulin. We have had insulin for a long time. For nearly 100 years, we have had insulin. Why have we not been successful in making insulin into a pill, while GLP-1, which came into market just about less than 10 years ago, has been made into a pill? Because insulin, like the GLP-1, is a protein, it's a peptide. And any peptide you take in the form of a pill gets degraded by the acid in the stomach and the enzymes. So since the discovery of insulin, we have been trying to make this into a pill. And hence they've been making it into microemulsions, nanoparticles, and several ways where they try to prevent this insulin from being degraded by the acid, and also to enhance the absorption of insulin through the intestine. We have used the same technology that we have used for this molecule GLP-1, but because it has not been cost effective and financially not viable, they stopped making insulin in the form of a pill, and hence we still have insulin in the form of an injection. But we have succeeded in making this peptide, oral semaglutide, in the form of a pill. So hence this talk on peptide in a pill, to say the benefits of this oral semaglutide. So the quest for the first ever oral peptide in the form of oral administration is to prevent enzymatic degradation and help with the permeability, and also avoid the effect of food on any of these pills, and hence to enhance the bioavailability of this molecule. So what did they do is they tagged this peptide with SNAC. SNAC is a sodium N-aminocaprylate. It is a small fatty acid. So they link these two together, and hence this SNAC kind of protects the semaglutide from breakdown by the gastric enzymes. So this is a smart move, which they tried with insulin, but it didn't work, but it is working with this GLP-1. And hence promotes the absorption across the gastric epithelium. So what happens is that the SNAC increases the gastric pH temporarily, and hence when the medicine degrades in the stomach, the SNAC, through a selective transcellular mechanism, takes the molecule through the gastric intestinal epithelium and hence into the bloodstream. So that is a very intelligent way to get a drug across the quite acidic medium in our stomach. So how do we administer? just remember how we explain to our patients to take their thyroxine supplements. So take it in empty stomach with 120 ml of water, and they wait for 30 minutes before they have anything else to eat or drink. So in that way, they take it in empty stomach and there is no food interference. So take it in empty stomach, wait for 30 minutes, take it with just minimum of 120 ml of water. And this oral semaglutide has got a half-life of nearly a week. So ask them to take it every day. Starting dose is 3 milligram. Because this molecule, this drug delays the gastric emptying, one of the major side effects is nausea and vomiting. So in order to build GI tolerance, you ask them to take 3 milligram, wait for them to develop the tolerance, wait for at least a couple of weeks, then increase the dose to 7 milligram. And once they're able to tolerate 7 milligram, then you can increase the dose to 14 milligram, which is the therapeutic dose where you would see the maximum HbA1c drop and a maximum decrease in the body weight. So, what evidence do we have? We have at least 10 phase 3A trials enrolling more than 5,000 patients across the world. So these are all the trials. They have compared this oral semaglutide with DPP-4, sulfonylurea, placebo, metformin, SGLT2 inhibitor with another GLP-1 with insulin, and also in patients with renal impairment. And there is a cardiovascular outcome trial looking into the superiority of this molecule. We know that the liraglutide has shown superiority, but with each molecule that comes out, they'll have to prove that it is cardiovascular safe is one thing. Another thing, an added advantage would be to prove it is superior and has got cardiovascular benefit. So I'm not going to go into the details of all the pioneer trials. The outcome, what they found in all these trials is kind of unanimous. What they found is a weight reduction of up to 5 kilograms, but in clinical practice, we see a lot more weight reduction. And you might be thinking a weight reduction of 5 kilogram in a 100 kg man is insignificant, but that would be quite significant even to reverse diabetes in that person. Irrespective of the BMI, we see a 5 to 8% reduction in weight and a HbA1c reduction of 2.9% in those with a HbA1c of more than 9%. So we will be able to achieve the golden target of less than 7% in these patients who have a HbA1c of more than 9% and a non-significant 21% CV risk reduction. Who do we initiate? So it's not something that you can just give to everyone. You'll have heart disease, CABG or heart failure. Then no matter what the HbA1c is, consider GLP-1 as a first line. You can use it at any course of diabetes. Even if the patient has had diabetes for 10-20 years, you can still use a GLP-1. When a diagnosis of type 2 diabetes is made, or when a patient gets discharged following a CABG or an ischemic event, you can start a GLP-1 irrespective of HbA1c. That is a take-home message. Another thing is, when there is a proven cardiovascular benefit, but the patient is not got any of this atherosclerotic cardiovascular disease, but you simply perceive that this patient is at a higher risk, then you can use this to minimize or reduce the HbA1c. When there is a need to reduce weight in your diabetic obese patient, use a GLP-1. And if the patient prefers an oral therapy, before you go on to insulin, if once you've tried 3 oral hypoglycemic agents and all you're left to give is insulin now, then you can trial this patient on an oral GLP-1 before moving on to insulin. Some of my patients who have put them on this oral GLP-1, I have even stopped their insulin because they respond very well to this GLP-1 despite being a diabetic for nearly 20 years. They seem to respond quite well, and I have even stopped their insulin. Obviously, it is not for everyone because of the cost factor, but consider this as a first or a second line in the patients who most need. Risk of atherosclerotic cardiovascular disease, it's after metformin and GLP-1. If heart failure predominates, then you may want to consider metformin and SGLT2. If the patient is obese, then you could use a combination of all these three. But the current hurdle that we have is that most GLP-1s are injectable, and all we have is just this oral semaglutide, which has been launched a few months ago. Oral semaglutide is expensive, I agree, and it is not for everyone. So you'll have to tailor it to the patient who are actually in need of this molecule and who would actually benefit from HbA1c reduction and weight loss. There are side effects at higher doses. I know of a patient who was put on 14 milligram of semaglutide straight away, and the patient came in with an impending diabetic ketoacidosis because he just could not keep anything in, and he continuously vomited for 2 days. So start slow and low, and then adjust the dose every 2 to 3 weeks. But on a positive note, it's the only drug effective for weight management. We have this Orlistat, as I said, you empty your pockets more than your weight. You lose about 3% of the weight, and it has got a lot of GI side effect compared to the GLP-1, and it is the only kind of drug effective for weight management. But the oral semaglutide, we don't have the approval yet to use for patients with obesity without diabetes. You can only use this molecule in patients with obesity and diabetes. But soon we will have the injectable form of semaglutide and perhaps a license to use oral semaglutide for patients with obesity without diabetes. And just like the other SGLT2 inhibitors and DPP4 inhibitors which have gone off patent, I hope and believe that we will have more oral GLP-1s, and they'll become less expensive and become more affordable for our Indian patients. And we have research on a new drug that is coming up, which is a combined GLP-1 and GIP-1 agonist, which has got promising results, and there are clinical trials show that they have lost 10 to 15 kilograms in weight, and the GLP-1 and the GIP-1 agonists work synergistically. So we yet to have this drug which has got a remarkable effect on weight loss. So I would like to keep it simple. This is my last slide. For every patient you see, remember there is a family member who is a diabetic. I always make a point to screen all my patients, even if they come for polycystic ovaries or hypothyroidism, aches or pains. I make sure they get their blood sugar checked at least once in 6 months, and all their family members screened if one family member is a diabetic. And prescribing a drug, you need to make a shared decision making. You cannot just prescribe a drug and expect a patient to take it. Make the patient agree with you, make the patient understand the pros and cons of not optimizing the glycemic control. So it's a shared decision making. That is the first step in getting the target under control. Next is initial combination therapy. Always start off metformin with something else. Don't start with metformin, wait for 3 months. Start off with an initial combination therapy and intensification. So every 3 months you'll have to review the patient and intensify the treatment if the previous treatment has not brought the HbA1c under control. Multiple risk reduction. It is not just about HbA1c reduction. It's not just about managing the weight. Make sure the blood pressure is in target, the creatinine is normal, the LDL is in control, the blood pressure, everything. The patient has had the eye screen, the foot care done. So multiple risk reduction should be very important and part of our consultation. And as a primary care team, patients come to you before they come to the doctors in the corporate hospital. By the time we get to see the patient, they have already got some microvascular and macrovascular complications, and we have already missed the boat. So when the patients come to you, make sure you screen them for all the complications, all the side effects of medications and diabetes, and also screen the whole family. You might be seeing one patient, but the whole family could be a diabetic. So we're not doing enough in screening patients for diabetes and the complications of obesity. So we rely on the primary care team in capturing all these patients early in the course of disease before the complications set in. Lifestyle changes is a continuous process. It's not something that we'll have to advise our patients in the first consultation. My patients will have to come and see me, especially when they come to see me for obesity management. They'll have to come with a food diary. They'll have to come and show me their app where they have taken at least 10,000 steps a day. Those are the patients who produce results in terms of weight loss, not those patients who do things in their mind or they come and tell you, yes, I did exercise. They'll have to show what they have done. So in terms of food diary, empowering the patient to do this on their own. That is again important. I tell them what I do is I'm just showing you the right path. Diabetes and obesity is unfortunately a lifestyle condition where the patient has to do most of the things. So I only show them the way and they'll have to do the rest. So empowering and re-evaluating the clinical situation at every consultation should be the core of our management. That's all I got to say today, and I'm very happy for being invited and for your patient listening. Thank you.
Extremely nice presentation, madam. It is, as you said, I'm an orthopedic surgeon, right? My friend called me to come for this, and it is from morning, really, I'm enjoying the lectures. In your, as you said initially, in the middle of your lecture, it is not only the heart, not only your kidney. Nowadays, most of the patients in our orthopedic problems, they have diabetic foot, and we are doing a lot of, within this for the past, I am doing for the past 40 years, my orthopedic practice. Within this 10 to 15 years, they go for more amputation of the fingers. As you said, loss, micro and macrovascular problems. And in your last slide, you said the primary care team should follow. Yes, all general practitioners, you are the primary care team. You should follow not only the patient, but the whole family. And nowadays, the vascular surgeon plays a major role in this. So it is our sincere request, it is with the hands of the general practitioners only, this type of obesity and diabetic control will help not only the patient and the family also. Thank you.
Thank you, sir.
And one doubt, madam, one doubt. See, I do a lot of joint replacements. When the patient comes with the diabetic, is it we have to continue with the oral diabetic, or we can change to insulin for 10 to 15 days till the suture removal, or what do you advise?
Okay, it depends upon the glycemic control. If the glycemic control has been good preoperatively, the patient can continue on oral hypoglycemic agents postoperatively. But because surgery and general anesthesia itself is a stress, so in the 24-48 hours after surgery, the blood sugars tend to shoot up, even in a patient with very good glycemic control. So temporarily, the patient will need insulin. You don't have to stop the oral hypoglycemic agent apart from SGLT2 inhibitor and GLP-1s. And sometimes if they're going to be bedbound for some time, I stop the metformin as well. A lot of factors come into play. If the patient is eating, drinking, stable, good glycemic control, continue the oral hypoglycemic agent, provided the blood sugars are less than 200. If the blood sugar shoots up to more than 200, top up with insulin, at least temporarily, to enhance the wound healing.
Thank you.
Sir, can you switch on the mic, sir?
TB patients also. Is it necessary? Likewise, is it necessary for the patients taking ATT to initiate the insulin and continue until the end of the treatment?
ATT mean anti-tuberculous treatment?
Yeah.
Yes, most patients with diabetes, most patients with tuberculosis have poorly controlled diabetes, and I put them on insulin invariably. You can continue the oral hypoglycemic agent, but I seldom continue on metformin because all these patients with tuberculosis are very lean, poor appetite. We actually want them to eat better, nutritious food. So I ask them to go on a high protein diet and invariably put them on insulin until I'm very, very happy that the blood sugar control is very good. Most likely these patients will need insulin on a long-term basis, but I will see them every month to assess the situation.
Thank you.
I am a practicing diabetologist, madam. I compliment your best lecture on semaglutide. One doubt, when you take the side effects of GLP-1, almost everything has got a central action except the nausea, vomiting, poor appetite. Is there a difference between oral semaglutide and other GLP-1 you give parenterally? This one doubt. Second, as you said clearly that an increase in pH in the stomach favors absorption of oral semaglutide. Suppose if the patient takes a PPI along with semaglutide, will it favor the absorption?
Okay.
Practical.
So I'll answer the second question first. So yes, it might increase the gastric pH,
Yes.
but it is not going to take the oral semaglutide transcellular. To get it transcellular, you still need a snack.
Yes, we
So
give
there are
that.
three things. You need three things. You need to protect the semaglutide from proteolytic enzymes. You need to take this semaglutide through the gastric epithelium, for which you still need the snack. So taking PPI alone will not work. It does
May
not
not
work. That's why we come up with the snack. The second, the
The
previous,
side effects, madam.
the side
Gastric
effect,
side effects.
the gastric side effect is the same
Same.
for injectable and oral semaglutide. So if you take liraglutide, dulaglutide and semaglutide, they still have nausea, vomiting, sometimes diarrhea. It's not because they take the pill, it's because it slows the gastric emptying. So I ask the patient not to eat a lot of food, because our patients are always under the assumption you take insulin, you can eat food. Okay, so you can have sweets, you take insulin, you can have Diwali sweets. So the same way, they should not assume you can take a GLP-1 and you'll start losing weight. Some patients will not lose weight if they continue to eat more, and I ask them to eat less. And the GI intolerance gets better. And to develop the tolerability, the reason you start at a lower dose and wait for 2 weeks is to develop the GI tolerance.
Yes.
So most of my patients have developed GI intolerance once they go over 7 milligram. As I said, 14 milligram is the therapeutic dose, but most of my patients have lost significant weight at 7 milligram. So I keep there and I'll see for about a month and then increase the dose to 14. So that's why I said go low and slow when it comes to GLP-1.
As a weight reduction regime, which GLP-1 gives the maximum weight reduction?
Okay, compared to liraglutide, semaglutide and dulaglutide are better.
Better.
Yeah.
Thank you.
Madam, these glutides is useful only for weight reduction and HbA1c reduction. Is it also useful to prevent peripheral arterial diseases? Is it useful to prevent peripheral arterial diseases? These glutides, only cardiovascular risk and weight reduction. Other than that, can it be used to prevent peripheral arterial diseases?
Okay, here, what he is asking is whether it provides protection in peripheral vascular disease also.
Peripheral-
Apart from,
PAD.
apart from
GLP-1.
cardiovascular, yes.
Yes.
Apart from cardiovascular.
Oh, okay. So most of the studies show cardiovascular benefit because that is what they study. They have not studied dedicatedly, they have not tailored a study to look for peripheral vascular disease. And it is a class effect. All GLP-1s, they seem to have a little bit of cardiovascular benefit, but the new FDA regulation is that each molecule has to prove it, and hence we're waiting for the superiority trial for the oral semaglutide. But so far as I know, they have got cardiovascular benefit, but not specifically studied for peripheral vascular disease. But I believe they will have the same mechanism of action when it comes to the endothelial function.
If it is so, it can be useful to prevent diabetic foot and other things, because the vascular component will be increasing. The
Yes.
gangrene and other things
Yes.
will not be there in
Can we
diabetic
have
foot.
this as the last question, sir? There is another question there. We will have this as the last question for the session. Thank
Like
you.
Vidhya, can we co-administer thyroxine with the semaglutide?
Sir?
Thyroxine with the semaglutide.
Can you prescribe thyroxine along with
co-administered.
oral semaglutide? I don't think why
We
we
need to
shouldn't.
advise patient to take thyroxine in an empty stomach.
Yeah.
The semaglutide also.
Thyroxine does not, okay, again, the reason to ask thyroxine to be taken in empty stomach is to avoid food interaction,
Yes.
not interaction with another drug. Usually the another drug does not inhibit the absorption of thyroxine, it's the food.
Okay.
So I believe they can still take it.
Thank you.
Yeah.
Thank you. It was a very interactive session. Thank you, Dr. Vidhya.
Thank
May I now request Dr. Arul Jyoti, diabetologist.